Good evening, everyone. I'm Shivani, currently pursuing Doctor of Pharmacy, and I'm going to present a case on antiphospholipid syndrome. Hope it helps all the other family students to learn a new topic. Our case involves a 52-year-old male who came to the clinic with complaints of high-grade fever and severe pain below left knee since 10 days. He also had swelling and black discoloration of left leg since 1 month. The medical history of patient involved he was already suffering from hypertension and systemic lupus erythematosus, and he was hospitalized for deep vein thrombosis of the same leg 6 years back. And he was suffering with similar symptoms when he was admitted to the hospital 6 years back. His medication history involves aspirin 75 mg, which was prescribed for the deep vein thrombosis that he was suffering, amlodipine for his hypertension, hydroxychloroquine 200 mg, azathioprine 100 mg. Both these drugs were prescribed for SLE. His family history involved pulmonary embolism and deep vein thrombosis. His mother was suffering from pulmonary embolism, and his brother had deep vein thrombosis. Objective data on examination, patient was ambulant with no apparent stress and stable vital signs. Lab parameters showed positive and elevated levels of anticardiolipin, antiphospholipid antibodies, and anti-beta 2 glycoprotein 1. These are the lab parameters which are especially used to determine whether the patient is suffering from antiphospholipid syndrome or not. And to confirm that he had deep vein thrombosis, partial thromboplastin time and INR was performed, which came out to be 27.5 seconds and 2.03 INR. Further specialized diagnostic tests performed was Doppler ultrasound imaging. It uses high frequency sound waves and is used to observe the blood flow. The left lower limb showed deep vein thrombosis with cellulitis and varicose veins were noted. Assessment, the diagnosis on the basis of subjective, objective, and lab data, the final diagnosis was made to be antiphospholipid syndrome. In this case, it would be secondary antiphospholipid syndrome since he was already suffering from systemic lupus erythematosus. The goals of treatment is to reduce thrombosis, to treat pain, to prevent progression of disease. Non-pharmacological treatment could be wearing graduated compression stockings, flexing the calves, and intake of food containing ginger, turmeric, and cayenne peppers. These food items are supposed to contain salicylates and salicylic acid, which could be used for blood thinning effect. About the disease, antiphospholipid syndrome is an autoimmune disorder that is caused due to antiphospholipid antibodies. These antibodies cause a state of hypercoagulability of blood, resulting in thrombus formation. About 35% patients suffering from APS experience deep vein thrombosis. It is the formation of thrombus or blood clot in major arteries and veins and also in small blood vessels. It is usually seen in the upper thighs and calves. Approximately 40% of APS patients are secondary to systemic lupus erythematosus. In females, APS results in recurrent miscarriage, preterm delivery, preeclampsia, eclampsia, and stillbirth. The diagnostic criteria involves presence of one clinical event, that is thrombus formation or pregnancy abnormalities, and two positive blood tests that measure lupus anticoagulant, anticardiolipin, antiphospholipid antibodies, and anti-beta 2 glycoprotein 1. Sapporo diagnostic criteria was published in 1999, which was used to diagnose APS in the early years, but recently it has been succeeded by Sydney criteria 2006, which says that at least one clinical event and two positive blood tests should be present in the patient. The treatment usually involves management of disease using anticoagulants and antiplatelet agents. The pharmacological treatment provided to the patient. The pharmacological treatment provided to this patient involved injection enoxaparin, subcutaneous route 6,000 international units twice a day, injection cefuroxime, it is a cephalosporin antibiotic, 1.5 gram IV 8 hourly, injection flucloxacillin, also known as fluxacillin, which is a penicillin antibiotic, IV 500 mg 8 hourly, tablet hydroxychloroquine and tablet azathioprine was continued from his previous medication for SLE. Tablet amlodipine 5 mg once daily was for his hypertension, and tablet aspirin 75 mg once daily was also continued from his previous medication. Pharmacist intervention, certain drug interactions were found in this case, cefuroxime and enoxaparin. Cefuroxime will increase the level or effect of enoxaparin by anticoagulation. Avoid or use alternate drug. Cephalosporins may decrease prothrombin activity. Intervention when using enoxaparin, it's important to consider dose adjustments tailored to the patient's risk factors, and treatment needs to minimize bleeding risks while maintaining therapeutic efficacy. Frequent monitoring is essential, watching for bleeding signs like easy bruising and gum bleeding, and assessing coagulation status through lab tests like prothrombin time, activated partial thromboplastin time, and anti-factor 10A levels to ensure patient safety. Particularly, anti-factor 10A assay should be performed for determining enoxaparin's efficacy in the patient, since enoxaparin is a low molecular weight heparin and it particularly acts on 10A factor. Aspirin and enoxaparin either increases toxicity of the other by pharmacodynamic synergism. Use caution or monitor. The need for simultaneous use of low-dose aspirin and anticoagulant or antiplatelet agents are common for patients with cardiovascular disease. Close monitoring of patients should be done. Another pharmacist intervention is the standard diagnostic criteria, which is the Sydney criteria 2006, suggests performing laboratory tests again to determine the antiphospholipid antibody levels after 3 months. If the levels are still positive and elevated, therapy should be continued likewise. Thank you.